My name is Mike Pishvaian. I'm an associate professor in the Department of Oncology at Johns Hopkins University School of Medicine. So pancreatic cancer is not the most common cancer, but is actually on its way to be the second leading cause of cancer-related death in this country. And probably upwards of 60,000 patients a year are going to be diagnosed with pancreatic cancer. Unfortunately, we know that the survival of patients with pancreatic cancer is poor, and we really need to make progress in this disease. We've had 2 chemotherapy regimens in the early 2000 teens that helped us take a step up in the treatment of this disease, but we haven't made much progress since then. And the only area where we've really made significant progress are in small biomarker-defined subgroups of pancreatic cancer patients. And about 25% of pancreatic cancer patients, their tumors harbor mutations in different genes that actually are predictive of response to different therapies, typically therapies that we wouldn't otherwise normally use for pancreatic cancer. This is a common misconception. I've had many people tell me, oh, pancreatic cancer does not really harbor any predictive genetic biomarkers. But in truth, there's been several studies, well over 8 or 9 studies, looking at well over 5,000 individual patients, and they all come up with the same result, that at least 25% of pancreatic cancers harbor genetic mutations in genes that actually predict for response to certain therapies. So the largest subgroup of these patients are those with a DNA damage response or repair pathway, or DDR mutations. Most classically, or most well-known, are the BRCA1 or BRCA2 mutations, but there's actually a number of genes in that pathway that can also be mutated. We know that patients who have mutations in the DDR genes do much better with platinum-based therapy. We actually studied this and found a 1-year improvement in overall survival for patients who had DDR mutations and received platinum-based therapy versus those who had DDR mutations and did not receive a platinum-based therapy. So platinum-based therapy is critical if you find an underlying DDR mutation. Then there's a number of smaller subgroups of patients, and I'll just run through the list of some of them. So for example, about 4% of pancreatic cancers harbor BRAF mutations instead of KRAS mutations. And of that 4%, 2% of them are the more classical BRAF V600E mutations. There are anecdotal reports of response to BRAF targeted therapy, and actually there's a trial ongoing trying to test that definitively to see if BRAF targeted therapy can actually improve outcomes for patients with BRAF V600E mutated pancreatic cancer. We know that about 0.5% of pancreatic cancer patients, their tumors harbor high degrees of microsatellite instability, and so the immune checkpoint inhibitors can be used for these patients and definitely can improve the outcomes for patients with MSI-high pancreatic cancer. Unfortunately, not as well as for other diseases, but yet if you see a patient with an MSI-high pancreatic cancer, they definitely should be given the option of immunotherapy or an immunotherapy trial. About the same percentage, about 0.5 to 0.7% of patients with pancreatic cancers, their tumors harbor fusion genes in the TRK genes and the NTRK genes, so NTRK 1, 2, or 3. If there is a fusion in those genes, then these patients are very likely to respond to either larotrectinib or entrectinib, both of which have been approved by the FDA irrespective of disease type. They're just mutation-based or fusion-based drug approval. So if you have a patient that has an NTRK fusion, you will be able to get them on label larotrectinib or entrectinib, and it really can make a dramatic improvement in the outcomes of these patients with pancreatic cancer. Then there are a number of other smaller mutations, many of which are being studied. There's a rare subgroup of patients who can have HER2 amplifications. There are some patients that can have NRG1 fusions, which can respond to pan-HER inhibitors, such as afatinib, or a neurodrug that's being tested right now in clinical trials. And then there are a number of other mutations that are being looked at as well. Now, one important thing that I'll mention about these biomarker subgroups of pancreatic cancer patients is that at the end of the day, it's still pancreatic cancer. And I'll use the MSI-high patients as an example. Recently, my colleagues at Johns Hopkins looked at their fairly large experience of treating a number of MSI-high cancers, non-colorectal cancers. And when they stacked up the outcomes of the patients with these different kinds of diseases, unfortunately, pancreatic cancer, which is always a difficult to treat disease, was at the bottom of the list. That even an MSI high pancreatic cancer patient, their response rate, their progression-free survival rate, and their overall survival rate were at the lowest of the group compared to endometrial, prostate, and all other MSI high non-colorectal cancer patients. So it just really is a signal to us that while we should use, for example, immunotherapy for patients with MSI high pancreatic cancer, we need to think about putting these patients on clinical trials, perhaps with different immunotherapy-based combinations to actually even get a greater benefit, a greater response rate, or greater progression-free survival, even for that biomarker subgroup defined group of patients. Additionally, I'll say one more thing about biomarkers is that our ability to test the tumors for genetic abnormalities that are actually key drivers of the tumor is expanding. So initially it was just genetic sequencing. Now RNA sequencing is becoming more routine, where we're looking maybe not for genetic mutations, but actually changes in the transcriptomics. And perhaps that will open up different avenues to treating patients who aren't producing RNAs or who are producing mutated RNAs that actually have some of the similar effects that we see with the genetics. And then the protein-based tests as well, one of which is the phosphoproteome, which are really the effectors of outcomes in cells. And there may be different phosphoproteomic changes that can occur that will define which tumors will respond to which therapies. But these are evolving diagnostic and biomarker predictive tests. But I would keep an eye out in this field because this may actually start to define how we choose to treat our cancer patients, and of course, pancreatic cancer patients being no exception.